Hi everyone and welcome to ABCs of Anesthesia. Today I have with me Vida filling us. Now, this is going to be an exam-focused podcast and YouTube video, obviously, where we're going to go through one aspect of the 2024 paper, the last one that people sat. And so I've got Vida, which is such a pleasure because we've known each other for a long time. You were actually the chair of examiners when I passed my exam. Thank you for passing me. Really appreciate that.
And I was just showing good judgment, Lahira.
Yeah, that's right. That's right. Imagine if I failed, how awkward this would be. But yeah, so you've done so much. Pretty much, you were you're obviously a FANSCA. You were an examiner for 12 years and chair of exams for 2 years for the final fellowship exam. You're also the chair of the ASA Education Committee, and you do so much great work for the ASA Education program that you have running. And also, you're the vice president of the ASA. So just amazing credentials, but most importantly, I think you're an absolute legend and you always advocate for people that need to be advocated for, and exams are hard, and that's why we're going to record this. So, welcome to, I think, is this our first chat on ABCs of Anesthesia?
I think so. We've done some podcasts before and we've spoken a great deal extensively offline, but it's a pleasure to be able to participate in this and to produce something that is of practical use to exam candidates coming up for their exams.
Absolutely. So what we'll do is the last exam, the 2024-2 paper, has very extensive notes. So what you've done is you've constructed a proper exam out of the exam that they've mentioned, with the examiner's notes as a guide, and with all your experience as the chair of examiners and knowing how ANSCA constructs exams. So I thought I would kind of run you through this and you would give us your thoughts on this particular exam and this particular. Here we go.
Sure. And just before we start, Lahira, I'd like to encourage the candidates to read the final examiner's reports. The examiner's reports at the moment are a template for the exams, as this exercise will show. There is so much information there that the examiners communicate about what they think is important that candidates should know and how they should approach their study and preparation for the exam. It is an absolute study guide for candidates as the report exists now. It's just provides such a wealth of information.
Yeah, amazing. And hopefully in the next few episodes, we'll actually cover, all of this exam.
Yeah. Go
through lots of the salient points and try to make it as practical as possible. So this first Med Viva, pass rate 81.5%. Great. You mentioned here it's a pre-op setting and includes preoperative management pre and post-op. And criteria are focusing to assess, interpret, assess medications, justify investigations to stratify disease, aiming to assess functional status and optimization. And so you have to have a good knowledge of pathology, integrate examinations and investigations, and identify significant history exam investigations to give maximum info about a patient condition. So that all sounds really reasonable. And I've got to say, Med Viva is the thing that a lot of us fear the most. So I think this will be a really great kind of start into that. So what I'll do, I'll read out the STEM, I'll read out the questions, and I'll get your thoughts on each point and how you can almost maybe answer it like the candidate would, but also have notes of what you're thinking at each time. So just for everyone listening, you're asked to review a 90-year-old male with interstitial lung disease in pre-admission clinic. He is booked for removal of a large fungating scalp lesion with a full thickness skin graft requiring GA. He is from a nursing home. He uses oxygen via a concentrator 18 hours per day. And there is a picture which you'll be able to see on the YouTube video, but it's quite a large, it looks like a 10 centimeter circular lesion, looks extremely fungating on the very top of his scalp. So just, anterior to the vertex. And then it goes on with past medical history, paroxysmal AF, hypertension, chronic back pain with insufficiency fractures, medications, pantoprazole, cefalexin, prednisone, 10 milligrams money, perindopril, metoprolol, 25 twice daily, and paracetamol, 1 gram, 4 times a day. His BMI is 18, blood pressure 125 on 65, heart rate 70 beats per minute. His oxygen saturation is 92% on 2 liters, respiratory rate of 18, and 36.6 degrees is temperature. So if you're listening, you might need to just rewind that just to get another sense of that, what the case is.
And I just want to say, the picture wasn't part of the exam presented scenario. I put that in because I want candidates, when they're reading the STEM, to think about exactly this patient. I do a lot of head and neck cancers, and this is what I see. It's a very useful presentation problem to think about this. Think about the patient in front of you. His BMI is 18. He's got a large fungating tumour. He's on an oxygen concentrator when you're speaking to him. That gives you a very good image of the level of frailty and disability of the patient. Yeah,
fantastic. Do we actually imagine that patient's probably a really useful thing? The question is, what features would you inquire about in his history to determine the severity and stability of his interstitial lung disease?
And when I ask candidates that question, you're the examiner now, I'm the respondent, I'll give you a little bit of background to what I say. The question is about the history to determine the severity and stability of his lung disease. I want to know how you will organise your answer. When you're choosing these constructs, they have to be simple. Otherwise, the construct becomes as complicated as the response. So how will you organise your answer? Quite simply, when you see a patient with interstitial lung disease, you ask them about the cause. There are heaps of causes of interstitial lung disease. Is it pulmonary fibrosis? Was this an exposure to asbestos, radiation, and so on? Or does he have some other connective tissue disease? The construct here is essentially a timeline. What was the cause? What was the antecedent for the disease? Establish that. And ask when the diagnosis was made, because for interstitial lung disease, the duration of disease has a significance for prognosis. So for those with severe disease, as this patient is manifesting, life expectancy is 3 to 5 years after diagnosis. And this speaks to decision-making for surgery already. This is feeding into that question. You ask them about treatment and its effectiveness. This man is oxygen dependent 18 hours a day, and the recency of diagnosis and the time of institution of oxygen is significant and has implications for his severity, stability, and prognosis. Here, he's also on steroids, probably for an inflammatory cause. Your job is not to ask the examiner questions, but you make note of that this is quite a modest dose of steroids. That's noted. You ask about complications, again, speaking to that timeline. Now we're on, how have you been going on this diagnosis journey? Have you had infections? Have you had instances of respiratory failure, admissions to ICU, requirements for ventilation? And then symptom trend. Dyspnea is the most common symptom for interstitial lung disease, and increasing breathlessness is a marker of severity. That's what you've been asked to determine, so that's going to influence that bit. Whether or not there's cough, whether cough is increasing, whether it's associated with sputum, an increase in respiratory rate. I can't remember what his respiratory rate was.
18, yeah.
We were told it's 18, which is not a normal respiratory rate, and whether or not he has increasing fatigue. A simple question about activities of daily living, which feeds your information about his level of frailty, is an important one. Does he need assistance? And ask him about recent weight loss. Has he always been skinny, or is his BMI of 18 an unusual development? Has that been a trend for him? So my construct is one of a timeline. What's the cause? When was the diagnosis? How he's been going on treatment, whether that's been increased, whether or not he's had complications, trends in symptoms, and his degree of frailty. So my construct is a simple one. It's just a timeline.
Yeah, perfect. And you can use my mnemonic for this is the SSCCT timeline. So
what's that one?
SSCCT. It's not great, but severity, stability, cause, complications, treatment. Because that encompasses it. And you can use that for history, examination, all three of them, two of them. But I'm glad we both use the same one. That's great.
Yeah, and I don't care what construct you use. Yeah. You don't have to use mine, but you have to have practiced enough Vivas that before you speak, you know how you're going to say it. You can even telegraph that or just say it explicitly to the examiner, and it's pleasing as an examiner to be able to follow your construct. So I think that's a really nice thing to do.
Yeah, Paul. You've got to hear more from history. I think we've mentioned most of this. That's what sorry, this is the information that's given. So,
More information for the evolving scenario, I think.
So you're given that this is idiopathic pulmonary fibrosis. Oxygen requirements are stable. Dyspnea is significant but unchanged. There's no recent infections. Only one hospital admission for pneumonia in the last 3 months. Weight has been maintained by pushing high-calorie drinks, and patient gets assistance with ADLs. How can you assess the frailty in this patient? And again, everyone who's playing along at home, feel free to just pause the video, have a go, say some answers, and we will move on to the answer now.
So this question, although purportedly is about idiopathic pulmonary fibrosis, now it has become a question about whether or not we should do surgery. An important part of that, and with our ageing population, it's clear to me that this question is about decision-making for surgery, and one of the ways that we do that is assessing frailty. I've actually got a frailty app on my phone, but I urge people listening to this Viva to imagine this patient. He's had a hospital admission. Somebody has to come and help him eat, dress, and so on, clean the home, all of those sorts of things. This is somebody who is, if you were going to stratify frailty, you can do it as a 1 to 10. You can stratify it as mild, modest, severe. This is at best somebody who has a frailty of moderate to severe frailty. He's practically in a wheelchair because he's linked to his oxygen hose. He's thin and he needs assistance, even though the supplemental history that we've just been given is reasonably encouraging. He's had no recent infections, only one admission, and he's able to maintain his weight, however modest that weight is, by high-calorie drinks. So I would put his severity, his frailty scale as moderately high. That's how I assess it. I don't think you have to get too fancy with frailty assessment, but you should be able to communicate the degree of frailty of this man. And he's 90. So either he's an elite 90, but he seems to have a significant degree of compromise. So I would just simply say, given all those things, he's of moderate to severe frailty.
Yeah, so I think you're right. Frailty, it's becoming such a big part of our assessment. It wasn't, back, say, 10 years ago. And just to give everyone who's listening a bit of insight, we've got this clinical frailty scale, which may over time be something we really want to know. 1 is very fit and 9 is terminally ill. He looks like he'll probably be at least a 5, maybe a 6, if you would agree. But even if you didn't, at this time, we're not, this is not necessarily part of the curriculum that you need to learn, but just to be able to go, this is moderate, this is severe, a descriptive sense of his frailty is really useful, because that terminally ill is going to be severely frail, and 1 is going to be extremely fit. And this is definitely on the upper end of that scale. But you wouldn't need to know these, this frailty.
Not all the details, I agree.
Yeah, beautiful. Top tips here. So it's not validated for less than 65-year-old patients. And you've got a baseline. Can they get better? So yeah, that's right. That 90-year-old, there's only so much this patient could improve by. And dementia decline follows a similar pattern. Actually, this was just for general information. What will you look for on exam to assess the severity of his interstitial lung disease?
So I created this question. So we're moving from history to examination now. You look for classical signs: cough, clubbing, and crackles. That's bog standard information that you get from a respiratory exam. But the examiners noted that they wanted candidates to describe a systematic respiratory examination: inspection, auscultation, palpation, or percussion. I asked candidates I'll ask you, Lahira, when was the last time you percussed a chest?
Ooh. It's actually in the last month, but before that, it was probably a couple of years.
Yeah, I must say, I do old, frail people with lung disease. I cannot remember the last time I did it. Now that I have access to, I use a stethoscope a lot, but I do not percuss chests because I don't think that I think I can get better information elsewhere.
Yes.
And I don't think any of my decision-making has ever turned on that, whereas I do think it depends on auscultation. So
I really agree with you. And it also,
Yeah.
it was a percussion because I knew there was a diagnosis and I was like, hey, look at this sound.
Let's see.
So I
Yeah.
completely agree. There's better way. It's not a high yield examination for me.
Yeah. And I don't think that candidates should work themselves up over omitting that. But inspection, auscultation, and palpation are very important things to do. Inspection signs of severity. So remember the question. You'll remember the question if you repeat it in your mind. What will you look for on exam to assess the severity? Well, on inspection, you'll note that he's underweight. You'll note that he's using or not using accessory muscles of respiration. Respiratory rate is here mildly elevated. He may have tracheal tug. You'll note that he's on oxygen. Cyanosis and body position, whether or not he can bear his own weight, whether he is standing or sitting, and whether or not he has clubbing. Clubbing's an interesting but non-significant sign. Clubbing's actually quite rare in life, but very common in the exam. So I urge candidates to make sure they understand whether or not it is a marker of severity. It's not always a marker of severity in disease. Auscultation will reveal signs of coincident infection, the depth of air entry, whether or not it's equal, and whether or not there are added sounds. Whenever somebody has respiratory disease, you must make sure that you mention whether or not there's any implications for cardiac failure. And when you talk about failure, candidates need to distinguish between right ventricular failure and left ventricular failure at brainstem level. You need to be able to whip off the signs of right ventricular failure and left ventricular failure, and to say RVF is more likely in the first instance, and then it may develop into CCF. Percussion, I don't care if you do percussion, frankly. I'm not interested in that. But make sure you do it systematically: inspection, auscultation, and palpation. And you palpate for nodes with infection and for peripheral edema for the instance of right ventricular failure.
And just to reiterate, from this, it looks like not only you're taking the stuff that you know and synthesizing it and saying, oh, that is a marker of severity, hence is underweight, but also you're thinking, what could this person have hypothetically that would indicate severity? So you have to think outside of what you can see right now.
Yeah.
Good. Should we go briefly through right ventricular failure versus left ventricular failure?
I always struggle with how much content we should deliver and how much we should deliver with respect to performance. If the candidates listening to this don't know the difference between RVF and LVF, you've got to go look it up.
Sounds good. So further information, the appearance of the patient is frail, thin, with an increased rest rate. There's no tracheal tug. They're not cyanosed, and they haven't got clubbing. They're not comfortable standing, so they're in a wheelchair with the oxygen concentrator. They have bibasal crackles and bilateral decreased air entry. The patient is afebrile. Have a think about that. And so assessment by review and investigation. So this would be, what do you see on this investigation?
I think the useful thing is to look at, so you're given pulmonary function tests, FVC, FEV1, FEV1 on FVC. It's useful. I never want candidates to read. This is not a reading test. It's difficult not to read aloud to avoid that dreadful silence during exams. But if there is a percentage of the predicted value, that's where the money is for your investigations. And here we're given an FVC that is 40% of predicted. The FEV1 is 40% of predicted. The what else is it? The residual volume, is 38% of predicted. Total lung capacity is 33%, and diffusing capacity, the DLCO, is 38%. What does that tell you? It tells you that this is already in the category of severe disease. So integrating the history that we know, the extra information we've received on that, and examination and now investigations, what we can say is that the severity of the restrictive defect is based on the FEV1 percentage value. And me personally, in my mind, I can't cope with any more than mild, moderate, severe. And this is the patient I had for a thyroidectomy yesterday that I saw in intensive care this morning. The reason he went, and he only had a hemithyroidectomy, he had severe degree of tracheal stenosis that was contributing to his dyspnea. He'd had a recent admission that was thought to be due to pneumonia for his chronic airways limitation, but ultimately was found to be food poisoning. Now, I would have liked a toe to assess his degree of pulmonary hypertension and right ventricular function, but it would not have changed what I do. I just presumed he had right ventricular failure. He was actually doing quite well, but his numbers were around that 30 to 40% mark, and he did not have any tracheomalacia, although he did have a big indent on his trachea, and he felt a lot better. I think we made him better after the operation. So that's one of the reasons why I proceeded without extra investigations, and he did go well. And I would have put him in a moderate to severe category of disease. The FEV1 is elevated or normal, and here the FEV1 is mildly comparable. The FEV1 on FVC is normal.
Yeah.
And the FVC is decreased and the TLC is decreased. This represents severe disease.
It's clear.
I think every time you're given the information, you say, great, I know a lot more about this patient than I did in the initial scenario. He's got severe disease.
Great. So clear, severe restricted disease.
Correct.
We know that because the FVC is so low and the ratio is preserved.
Yeah.
Good. So severe restricted disease based on the F1 percentage, mild, moderate, severe. FEV1, FVC elevated or normal, FVC is decreased, to lung capacities decrease. Great, this is severe disease.
All typical of severe respiratory disease.
It's very nice of you in this to not make it too complicated with mixed pictures. Nice.
Yeah, and I think it's important to understand. So get clear in your mind what an obstructive picture looks like, what a restrictive picture looks like, and then comment that this is either satisfying or unsatisfying and not a binary choice, as it often isn't in people.
Yeah, absolutely. Spirometry. So here we go. So
what I'm interested in candidates being able to do is drawing that very nice diagram that includes a normal curve, an obstructive curve, a restrictive curve, and what pulmonary fibrosis looks like. They are also, I'm not going to describe them to you qualitatively here, but you must be able to move those curves along the x-axis, which is volume. You must be able to label them and put units on them. Do not come to the exam without this knowledge.
Excellent. What would you expect with an ABG? So, yeah, this is a good question of, you've got to think hypothetically.
Yeah, I recreated this exam from the examiner's report in my own imagination, and I didn't actually put the numbers down. I didn't actually put all the numbers down, but I commented that interstitial lung disease disrupts the exchange of oxygen and CO2 at the interstitial level, and a restrictive defect develops. This patient might have a hypoxia, and he's on oxygen. We know he has a hypoxia, and a hypoxia-mediated respiratory alkalosis. We do know he's got an increased respiratory rate, so I would expect the CO2 to be low. That's what I would say. And then the compensatory changes.
Yeah, good. It doesn't seem like numbers, they wouldn't be.
You should be able to interpret it. And if you are given numbers, I think you should say, instead of saying this is hypoxia as defined by, and you should know, the other thing I should mention is you should know how to evaluate numbers on somebody who's oxygen dependent. They need to be off oxygen for a significant number of minutes, 5-10 minutes, before you take the gas, for it to be informative. You should know that what the normal numbers are, what the normal compensation would be, and what you would expect. That's what you should say. As expected, this patient's hypoxic. As expected in this patient with an elevated respiratory rate, the CO2 is low. So it's a metabolic alkalosis and hypoxia.
Right,
So
you've got the PaO2 at 50 off oxygen, and PaCO2 at 30 millimeters mercury. Unfortunately for the listeners, won't be able to see this chest X-ray, but please check out the video.
And I'll describe it to you that pulmonary fibrosis causes reticular shadowing of lung peripheries, which is typically more prominent at the base, and that obscures the heart border. The X-rays aren't particularly crisp, but they are typical. The chest X-ray may be useful in monitoring progression of interstitial lung disease, but more often these patients get surveillance CTs. Yeah. And the the site that I use is Radiopedia. I think it's great.
Yeah, it's a great site for that. So we've got a bit of information here. We've got fibrosis, same patient as the image above. 20 months later, as the disease progresses with the fibrosis, becomes more widespread and leads to lung volume loss. You might be able to see here because you can count ribs. In the midclavicular lines on each side of the diaphragm is positioned above the level of the fourth and fifth ribs on the right and left, respectively, compared with the image above, which showed normal lung volume. And so, yeah, it's probably a good example that you're likely to get some level of lung disease to know that that's what reticular pattern looks like. And the other common one is kind of the sarcoidosis picture of a reticular nodular pattern as well. But again, these are things that do come up on the exam. I think reading chest X-rays for those things, it can be quite difficult in the exam.
And important to say, as expected, this is what I find. And if they show you a normal chest X-ray, say, what I'm looking for is this reticular pattern. I'm looking for infection. I'm looking for loss of lung volume. I'm looking for a hilar lymphadenopathy.
Excellent. And here we have an ECG.
And the ECG, for your listeners, let's go straight to the money. Tell me what you expect. And you must be reading ECGs systematically and comprehensively. Tell me whether it's sinus rhythm. Tell me whether it's sinus or tachy. Tell me what the axis is. And I want you to calculate it using lead 1 and lead AVF. Tell me that the intervals are normal, but bang off quickly. A normal PR interval is 200, a normal QRS is 120. The QTC you can estimate. I'm not asking you to do square root calculations in your mind, but you need the machine time. You need to know whether it's above or below 440. I know it's different for men and women. My personal mind cannot cope with all those numbers, different numbers for men and women. I just use 440 milliseconds and comment that there is or is not ischemia.
And I'll be thinking, yeah, obviously there's a normal ECG to go for the money. There's some level of widening QRS complex, and you then define whether there's a bundle branch block of some sort. I think the expected things you'd want to say, I'm worried about any kind of right heart strain patterns.
Right.
That's what I'd be looking for there. And then, QTC, it's really annoying. Realistically, I look on the readout and that tells me a corrected QTC. But as long as the T wave ends before half,
all right. Oh, it's a good rule of thumb. Yeah. And that's the other thing. QTC that's prolonged is not that common in life, but it is common in the exam, not because examiners want to torture you, but because they want you to know something about the electrophysiology of the heart. And it makes you look 10% smarter if you're not consternated by a discussion about QTC.
Exactly. Is that ECG as expected?
Mm-hmm.
And have a think about that.
And what I wanted to provoke the candidate to think is whether or not this is consistent with the picture that we've had as the story so far. Pulmonary fibrosis or interstitial lung disease may be associated with connective tissue disease that may be a cause of interstitial lung disease, or in this 90-year-old patient, these conduction abnormalities. In this patient, I think they had a right bundle branch block, and that is associated with a heart that is also 90 years old with coronary arteries that's 90 years old. So don't forget the context for the patient.
Yeah. Good. What about a 6-minute walk test?
Now, this is a common test and a very useful test, the logistics of which candidates should know. You put 2 markers, I don't know, a couple of 100 metres, or I don't even know, is it 70 metres apart? I can't remember. And you ask them to walk for 6 minutes. This is not practical for a man who's towing an oxygen cylinder, and it's unlikely that this patient could complete a 6-minute walk test, but the candidate should know that useful information about functional capacity can be gained from a 6-minute walk test. Of course, this guy can't do the 6-minute walk test. So initially it was used to assess cardiopulmonary issues, but now there's wider application of the 6-minute walk test, including neuromuscular system, integrity and peripheral circulation. A difference of 45 metres suggests an actual change, and it's primarily used to assess the response to treatment. It's a good test. It's got good reliability. Here, introducing the only statistics, well, I shouldn't speak in absolute terms, but candidates should know what reliability is and what validity is for a test. And this is a test that has good reliability and good validity for correlation with other tests of functional capacity. The normal is 400 to 700 metres. It's easy, simple, low risk, but non-specific.
Excellent. Great. And we've got here some mean distances in meters by age and gender. So think of your 60 to, so in your 60s, 572 meters, females 538. In your 70s, 527 for males, 471 meters for females. In your 80s, 417, 392 for females. Moving on, we've got here from the exam report. So every exam report is linked to learning objective, which is great.
Yeah.
And so your question there is discuss how abnormal common perioperative abnormalities of common perioperative investigations will affect perioperative management.
Discuss how abnormal common perioperative investigation will affect perioperative management. And then that was what the examiners commented. One of the questions that I had in my mind was for the candidates was about the difference between VBG and ABG. This was before the written paper that I created this question, and I hadn't seen the written paper yet. And so candidates answered this in the written paper. I asked it in the Viva.
Oh, no.
And the most significant difference is that PO2 values compare poorly and you're not able to comment on hypoxia from a VBG, but you get good information otherwise. And in summary, you integrate all of this information that you've had from history, the evolving scenario, examination and investigations. You say on history, his condition is stable but severe. He's oxygen dependent and has low weight. That's consistent with an increased work of breathing. He's underweight and possibly malnourished. Examination findings are consistent with severe disease, but fortunately for him, there's no coincident infection. The investigations are consistent with severe disease on blood gases and pulmonary function tests. It would be interesting to note what his trend has been over the last little while, say several months, to check for stability. I would consult with carers and his respiratory physician for further information. In summary, he has severe disease, is constitutionally impaired, and is old. You don't have to get any fancier than that. And on the information, what can we improve? His nutrition may be improved, and there is no respiratory infection to treat. I check with respiratory physicians regarding any optimization. You and some of your listeners may know I do some annual work in Africa doing anesthesia for thyroid surgery. And one of the difficult things there is in preparing patients for surgery is getting their BMIs high enough for them to be able to heal post-operatively. So don't disregard the importance of simple exercise investment for these patients and an investment in better nutrition.
And so this was so the question is procedure will be scheduled in 2 weeks. How will you prepare him for this surgery? And I can imagine, so, consider the surgery, delayed, modified, cancelled, alternatives. These are all important things. Advanced directive, the aims of the surgery, prospects of survival, quality of life, morbidity. So all the relevant questions that you absolutely ask before any operation, but especially in this one with someone who's so frail. And then if you were asked the question in this exam, look, would you go from everything you know right now? What's your feeling about whether you should proceed? Obviously, there's so much more to know from the surgeons, and pathologists, and everything about this. I would not recommend surgery for reasons of futility, and also just check with anyone who did this fine.
Yeah. No, it's always interesting to talk to candidates. And in fact, I did talk to a few candidates who had done this Viva, and this wasn't a big part of it for the people that I spoke to. That may be because they hadn't had time to get through all the questions, but you would certainly hesitate in this patient. As a consultant anaesthetist, I do this sort of surgery. I would talk to the surgeon and talk to the carers. What are the prospects for healing? Because somebody who has such an oxygen dependence and such a big area to be operated on, I would worry that we would not improve this man's life. Do we have alternatives? Can we cut out a little bit of a chunk of this? Is this making this patient's this patient repugnant to his carers? Does he need some sort of cover, some sort of dressing for this so that it wouldn't smell? All of those things. Radiotherapy might be an option. If needs be, I would certainly be able to participate in an anaesthetic for this patient. And I think I could do it safely, but I don't know that the extra insult of surgery would be in this patient's interests. And I think that's what the examiners want, a rational discussion about the cost and benefit of surgery in the elderly patient with a lot of comorbidities.
Yeah, I totally agree with that. Like having this is the pointy end of things with any kind of risk benefit. Most patients come to an operation, they go ahead with surgery, but this patient suddenly now, what is the benefit? Obviously cut it out, but is that curative? And especially when someone's only got so long to live with severe restricted lung disease and interstitial lung disease, you'd think, could you just debulk this tumor much less of a problem, and they would have their longevity without absolutely dying in the next 60 days.
And it is interesting to me to consider, not in a dismissive way, but this tumour is now of 10, 12 centimetres in diameter. It didn't grow overnight. You want to know why this patient delayed. Maybe they were fearful. Maybe they didn't actually want treatment. I think the important individual to consult is the patient as well, and what can be done in their best interests. It's really not possible to answer this question without further consultation, but I would certainly have a big hesitation in my mind about proceeding.
Absolutely. Vida, that was Viva. Thank you so much for constructing that. I think, that was a really great use of our just the really great examiners and reports and being able to go through a whole question.
Yeah, it absolutely speaks to the huge resource that is the examiner's report. And I'm not saying that the examiner's reports and previous exams should be the only thing that you use to study for this exam, but there is so much information there. It also tells you about what the panel is thinking, what they think is important for this exam. And I think the fact that it is based on learning outcomes represents excellent use of educational theory. That's how you should base training and assessment in candidates. And I think it represents an extremely valuable and extremely transparent resource for candidates. You can't say you don't know what's going to happen in the exam with exam reports that are so full of excellent information.
And if you, my strategy for studying for this exam was, you have to work through your syllabus points and, get through the content. But at the same time, I would start, even in your first month, just start looking at these exam papers and doing exam, maybe even constructing Vivas because of the utility of, like, even us. Like, imagine when you're constructing the Viva, just gathering information like the Frailty.
Yeah.
That's a really useful thing. I know it's very useful for me to relearn a lot of things and see what the new data is. So please use this, and then potentially as it gets closer to your exam, you'll be far more less book learning and syllabus learning, and more exam focused learning. But that should start straight away.
And also, it's if you think for a Viva you can prepare in a quiet room, you're making a big mistake. You have to do it out loud. You have to do it in front of a camera, and it is the greatest humility test to actually watch yourself on a Viva so that you are using a simple construct, not using filler words. You as a podcaster and myself as somebody who makes a lot of videos, I know how diabolically hard it is to avoid those filler words, and there's plenty of information on the net with giving you information about how to stop using filler words. It's a skill that I have yet to perfect, but I try every day.
Beautiful. Hey, Vida, thank you so much. I think that's a great little segment. Let's reconvene at another time. We'll go through another Viva or some of the examiner's points. Thanks for watching and listening. And please share with anyone who might be interested. And good luck for your exam study. See you next time.
Thank you. Bye.
Now, what's new with ABCs of Anaesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anaesthetic journey, from medical student to procedural skills, from foundations in anaesthesia, as well as really important exam lectures and clinical anaesthesia courses as well.